All right. Okay, thank you, Claire, for joining us today for our special with Awareness Week. So today we've got Claire, who's an OT in London, and she'll be talking to us about FND and OT. I'm the president of FND Australia Support Services, and Julie is our online support director. Share my screen.
Thanks, Kate. Thanks, Julie.
Let's go ahead. Having problems sharing my screen. Sorry. Okay, cool. I've got my slides here. Okay. So, Claire, would you like to tell us a little bit about your role at the National Hospital for Neurology and Neurosurgery in London and what you do with clients with FND?
Sure. So I'm an occupational therapist and I specialise in neurosciences, but I'm also a specialist in functional neurological disorder. I'm the physical therapy, so occupational therapy and physiotherapy lead for an inpatient and an outpatient rehab program specifically for FND at the National Hospital for Neurology and Neurosurgery in London.
Okay.
Yeah.
Excellent. Okay. Well, as you mentioned, you work with a multidisciplinary team for functional neurological disorder. So there is evidence emerging around the role of, MDT, multidisciplinary team for functional neurological disorders. What's the role of an occupational therapist within this team in terms of treating people with FND?
So I guess if we're thinking about the role of OT in general, the role of OT in treating FND in general might be quite different depending on the setting that the OT works in. If we're talking in the context of inpatient or outpatient rehab, basically the occupational therapy role will be very much based on what the patient outlines as their problem area or the goals that they set for rehab. Because as we know, occupational therapy is a goal-directed therapy. So what we would initially do is sit down with a person and work out how their functional symptoms may be impacting upon their ability to engage in day-to-day activities. And then we set goals from there. So it could be anything as broad from intervening at having problems with doing their own personal care, or it could be things in the home such as domestic tasks or parenting, having problems with parenting. It could be as looking at community access or going to university or going to work. So the occupation in occupational therapy doesn't just refer to paid occupations. It also refers to any other daily activity that someone might need to or want to be engaged in.
Yeah. And in terms of people with FND, you're looking at they've got symptoms which impact on their daily life. So you're looking at sort of the impact of the symptoms and doing any interventions around them as well.
That's right, yeah. So the interventions would depend on what the symptom type is. So, for example, and I think we'll talk about this a little bit later, but if it's specifically functional movement disorder, so functional movement disorder obviously will impact upon a patient's ability to engage with their environment and engage with their day-to-day activities. But along with functional movement disorder also comes other symptoms such as chronic pain and chronic and fatigue. That very commonly goes hand in hand. So it could be an occupation-based intervention, but it can also be education around the symptoms and around symptom management strategies.
So maybe things like pacing?
A lot of fatigue and pain management education. So talking to the person about what the mechanisms behind chronic fatigue and chronic pain might be, how that can interact with their ability to do their day-to-day things, such as kind of like a boom-bust pattern of behaviour.
Yeah.
And pacing within normal day-to-day activities.
Yeah.
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 Yeah. Yeah.
Okay. And what we're seeing a lot now, we've got NDIS, and we're often having people saying, "I need a functional assessment."
Mm.
So for someone with FND, what does a functional assessment look like?
Yeah, so we do our occupational therapy assessments in 2 stages. One would be an occupational analysis. So what that means is that we would sit down with the person with FND in a talking capacity, and we would work out how their functional symptoms are impacting upon every single thing that they do day to day.
Yeah.
Everywhere from from personal care to accessing the community. And we would break down the task components of that personal care or that kitchen task or that community access, and work out how that person is on a good day and on a bad day. So when their symptoms are a little bit better, when their symptoms might be particularly bad, and see whether there's any discrepancies between those two in terms of are they functioning at kind of this kind of level all the time, or do the symptoms wax and wane? And if they wax and wane, what's the occupational engagement like?
Yeah.
And part of that is looking at what a person's 24-hour routine looks like. So we would look at, what they're like from the time they get out of bed to when they go to bed at night. Are their symptoms meaning that they have lots of care needs during the day? Is the sleep-wake cycle out of whack? Are they sleeping a lot during the day and have poor sleep at night? What's the occupational balance like? So what I mean by that is, do they have very little activity to engage in during the day, or are they trying to take on too much and they're kind of getting a burnout?
Yeah.
The 24-hour routine can really help to outline the impact that the symptoms are having on their day-to-day routines.
Yeah. Oh.
And then the second component, of course, is an activity analysis. So what that means is that the occupational therapy would ask the person with functional symptoms to undertake a daily activity while the OT is having a look at how their symptoms are impacting upon their ability to do that activity.
Yeah.
So that could be having a look at the person doing transferring from bed to chair or chair to bed. It could be having a look at them in the kitchen, doing a kitchen task, or getting out in the community. Anything that the patient identifies as being quite challenging. And then what the OT would do is then sit down with the patient afterwards and speak to them about what they're noticing and what they're noticing about how the functional symptoms are impacting upon their movement or their ability to engage in that task. And we actually find it quite helpful, Kate, to sometimes, with the person's consent, we video that assessment.
Okay.
And then we sit down with the patient afterwards and we show them the video, and we first of all ask the patient what they're noticing about what's happening with the way that they're moving or the way that they're doing that task. And then because that helps to increase insight, and we know that increased insight in symptoms is linked with better self-management. And then from looking at that and speaking about the results of that assessment, then we work out a plan jointly with the patient about which areas we might be able to intervene at and what goal areas we might be able to tackle within the confines of our intervention period, because the intervention period will be different depending on what setting you work in.
Yeah, exactly.
Yeah, does that make sense?
Yeah, no, that's good. Yeah. Okay, and then this will sort of head into interventions that might be made. The things that are quite common with FND are people who have the seizure type disorders, and I think you call them non-epileptic attack disorders in the UK, and also the functional movement. So a lot of people have difficulty walking. That's a very common symptom. They're the two sort of main symptoms that people are dealing with, along with, of course, chronic pain and chronic fatigue. So for each of these, what type of recommendations might you make to help people, manage the seizures, self-manage the seizures, or, what type of things might you do if people are having, struggles with walking, which then, of course, impacts all their occupational things that they might want to do in the community, at work, with study, etc.
Sure. Well, in terms of functional seizures, so we know that the evidence base behind treatment for functional seizures kind of lies with psychological therapies at present, and in particular with CBT and psychotherapy. So if that is available for patients with functional seizures, then OTs can work alongside psychological therapies with the patient with functional seizures. But in the absence of psychological therapies, because they can be difficult to access depending on where you live, OTs can still, occupational therapy can still be really helpful. So where we probably start is working out what the patient knows about their seizures. So have they identified any patterns or any triggers? So what I mean by that is that, do they notice that their functional seizures might come on when they're in a lot of pain or when they're fatigued? Might they come on when they're in quite busy areas, or after they've had an argument with someone, or when they're particularly stressed from work, for example? So again, we're just trying to increase self-awareness about what the triggers might be. And then depending on what the triggers identified are, the OT can then intervene at that level. So it might be about doing some pacing education around fatigue and pain management. It might be looking at things like anxiety management or stress, things that might make the person more resilient to stress. So depending on what those triggers are that the patient has identified. If work is a maintaining factor, the OT might get involved with helping sustain someone in work, for example.
And that's what we've had is work and school, and they've been requesting seizure management plans as well.
So that's exactly. So occupational therapists combined with the rest of the patient's treating team can develop seizure management plans. So that could be twofold, reasons for twofold. So if for significant others, the seizure management plan might outline a plan as to how that person with functional seizures might like their seizures to be managed within the home and within the community. So as to prevent having to go to A&E all the time. Because we know A&E can be quite a distressing environment when people have functional seizures. But also, if someone does end up in A&E, a seizure management plan can be really helpful because it can outline, first of all, that the patient has functional seizures and what that means for the person. So how they present, whether they can hear, whether they can see, how they like their seizures to be managed. For example, many patients don't like to be given sedating medications, but when they end up in A&E, they quite often get given a lot of sedating medications, which can then make the recovery process much more difficult. So a seizure management plan can be really, really helpful. And then also the other thing that occupational therapists can do is, again, around increasing the self-awareness. Many patients have a lot of anxiety, but they might not necessarily recognize the signs of anxiety in their body, and helping to increase that self-awareness of what that anxiety might look like. Because if someone's had a high level of stress for many, many years, the body kind of accommodates to it. And so, you know, I mean, my boss often says I wring my hands and wring my elbows. I don't even know that I'm doing it.
Yeah, yeah,
So,
yeah,
so as OTs, we can help people recognise what the signs and symptoms of stress and anxiety might be, so that then they can start to look at some management strategies to help intervene before their anxiety gets to a point that might lead to a functional seizure.
yeah,
And then, of course, there's grounding strategies, which you know, was developed by psychological therapies.
yeah,
Strategies that try and keep people in the moment. So noticing detail in the environment around them, distraction techniques, conversation, touching different textures, trying to ground them in the moment so that their body is focused, their brain is focusing on something else rather
yeah,
than the trigger to the
yeah,
functional seizure.
yeah. And getting, you
Yeah,
know, panic and escalation, because often, you know, a seizure can just increase anxiety, and people are anxious that they're going to have a seizure when they go out, so then they don't go out. And, you know, you can get that cycle, you know, that you're anxious and then you
exactly,
have a seizure and then you're more anxious and just escalates.
exactly.
Yeah,
Yeah, so that, I guess that's that. You know, there's lots that OTs can do, but graded task practice is another
yeah,
really important
yeah,
intervention strategy for functional seizures, because
yeah,
many people with functional seizures understandably might disengage from activities that might be difficult, or they might be fearful of doing, for example, as you mentioned, going out.
yeah,
So we would approach that activity in a very graded way,
yeah,
combining the use of intervention strategies or management strategies for their functional seizures,
yeah,
whilst undertaking a task that the person's identified as being difficult or stressful.
yeah, yeah. And building people's
Yeah,
confidence back up as well. Yeah,
exactly. Yeah,
yeah,
because that's certainly something that functional seizures does. You know, it really knocks people's confidence, which is
yeah,
completely understandable.
yeah, yeah. And
Hmm.
people here have had bad experiences when they've had seizures in public and they've been treated appallingly. So that increases people's anxiety about going out and being around
Mm,
people in
of
case they
course.
have a seizure in public. Yeah, yeah,
Of course, yeah. And that's where, you know, maybe carrying a seizure management plan can be really helpful as well,
yeah, yeah,
in case they get taken to hospital or paramedics are called.
yeah. And bystanders can get quite overwhelmed if they don't know what to do, if they don't know the history of the person. It can be quite scaring and overwhelming for bystanders too. Yeah,
Of course, definitely. Yeah, yeah.
yeah, yeah. And so
Mm,
the other major issue, of course, is functional motor disorders. And
mm.
a lot of people have problems walking. Some people are paralysed. Some people have left-sided weakness, right-sided weakness, both-sided weakness. And that can, you know, if you can't get around, it changes your whole daily activities, not able to do what you want to do.
Of course.
So what do we do with someone that's having difficulty walking that's impacting their ability to do what they want to do, to engage in what the activities that they want to engage in?
Yeah, so occupational therapists alongside physiotherapists would tend to kind of start at the basics, really, where we would have a look at how the patient is moving, or the person is moving within their transfers, and having a look at what we're noticing. So are we noticing that the transfer is coming completely from the upper limbs or the arms and hands, and
Yep.
there's very little weight going down through the feet? Are we noticing that someone is transferring, like pushing up with their elbow crutches, which in itself can cause problems with arms and shoulders? And you're looking at how they're weight bearing. Are they weight bearing on one side versus another? Is it quite uneven? And you intervene at that level as to what you're seeing within those functional transfers. Um, we would look at implementing normal movement strategies, so getting forward momentum and even weight bearing within the transfers within standing. And then you're integrating those normal movement strategies and even weight bearing strategies within function. So over short distances, but they're walking to improve quality before you add endurance. Standing to brush their teeth, standing to have a shower, standing in the kitchen, looking at strategies to improve efficiency of the body's movement. So, because as we mentioned before, functional movement disorders can be really exhausting, and they can cause secondary pain issues as well because of the bad habits that the body picks up. And of course, and then you'd integrate that into longer distances outdoors. If a person is unable to stand weight bear, then we would take it back a notch, obviously, and we would look at graded weight bearing within functions. So you might do that in terms of looking at perch settings. So what I mean by that is having a slightly raised seat, either from the side of a bed or from a therapy plinth or from a perching stool. And what you're doing is trying to engage the person in a functional task using their hands and their arms, whilst they're getting a little bit more weight down through their feet. And the reason why we're doing that is to try and improve the sensory feedback that's coming up through the patient's or the person's feet and legs, trying to give them a normal sense of sensory feedback through their lower limbs. And then then we would just gradually increase the height that they're standing or they're sitting at, to try and increase that sensory feedback as well. And you might do that. We spoke about the fact that confidence is really important, and coming up on your feet when they feel really weak is really quite scary. So you might actually do that with a raised plinth that they're sitting on, but also a raised plinth in front, so that they don't feel like they're going to fall or go anywhere. If someone doesn't have any sensation in their legs, that is an added level of complexity. So what we would often do is do joint therapy sessions with physiotherapy or with a rehab assistant or technician. And we might actually get the person who has the movement disorder and sensory problems up into a standing frame, where again we're promoting sensory feedback through the legs, but also the person is kept safe, and they're made to feel more supported in a standing frame whilst we're doing an activity using their hands and their arms. Because using the activity, doing an activity with their hands and the arms is a form of distraction as well. So the person is not inadvertently focused on what's happening in their legs. So, and of course, OTs can also, with functional, can also intervene if someone's having functional movement disorder that affects their upper limbs as well. So that could be tremor, that could be weakness, that could be dystonia in the upper limbs as well. So what we would do is, again, look at the actual problem that the person is experiencing and look at intervention strategies to either, in the case of tremor, we might look at tremor entrainment or helping to switch off accessory muscle use and trying to reduce co-contraction in the upper limbs. In the case of someone that might have functional weakness, we're trying to integrate that upper limb as much as possible and as normally as possible into functional tasks, so that people don't kind of develop a learnt non-use of the upper limb.
You mentioned functional entrainment, perhaps you could, or tremor entrainment, I think. Can you explain to people what that is? Tremor entrainment.
I mean, there's lots of, you could probably, for people that are not familiar with tremor entrainment, you can have a look on YouTube and see quite a few examples. But it's basically what we know with functional tremor, particularly upper limb tremor. It can be driven by an inadvertent focus on the symptoms. So with tremor, inadvertent focus and without conscious control, tremor can be elicited. And so what can happen is that if focus is redirected to, say, for example, the opposite upper limb, you can teach the person strategies to try and divert attention to the other upper limb. And what can then happen is that because the focus is off the tremoring upper limb, the tremor can start to settle.
Yeah.
And that can be used twofold. One, it shows people that the tremor is changeable, and therefore, it can show them that the tremor is not there all the time, and therefore we can actually intervene and can change that. But also, the beauty of occupational therapy is that we use activity and function as a form of distraction.
Yeah.
So you will often see that particularly with functional upper limb tremor, if you get someone engaged in an activity where they're really focusing on something else, such as in the kitchen, that actually their tremor might start to reduce, or the frequency might not be as much, or it might not be there at all whilst they're really engaged.
Yeah.
So that can be really, really helpful.
Yeah. Yeah. Cool.
Yeah.
And then going back to walking, one of the problems that we've mentioned, chronic fatigue or weakness, and the difficulty with endurance. Some people might be able to walk a few paces, but not be able to perform any sort of functional. They're not able to walk to the bus. They're not able to get to work. They're not able to make it to the school building. So what do we do when people are having difficulty walking that's also related to endurance, and it's not functional? Basically, the walking is not getting them where they need to go.
Yeah, so I guess it's twofold there, really. We use what we call a graded goal setting approach. So we would really have a look at once kind of sitting down and doing lots of kind of pacing education. And then we would set graded goals as to how we might very gradually increase someone's walking endurance.
Yeah.
And sometimes that might be combined with using aids and adaptations in the short term or in the long term, depending on the patient. So, for example, we often will get patients that come in to our inpatient program and will be using a wheelchair for all mobility because their walking endurance is reduced.
Yeah.
And what we might do is set very small goals about walking even around their bed space in starting point, or walking to the bathroom as a starting point, and then using their wheelchair for the rest of the time on the ward, and then gradually increasing that.
Yeah.
We wouldn't just go in and take away someone's wheelchair. It's always done in a very graded way, with a clear pacing plan in mind. And then as the patient's capacities improve, then we gradually increase the amount they're walking, and we also look at changing the environment that the person is walking in.
Yeah. Yeah.
Okay.
Yeah. And the other thing to be mindful of, I have a picture of crutches here. I know when I came down with FND, which wasn't diagnosed for a number of years, was initially diagnosed as a stroke, and I was sent home on a pair of crutches like we have on the screen. And I was dragging myself around on the pair of crutches, and I ended up with severe pain on my shoulders. So it's also around, not prescribing harm, basically, because I know that the crutches did a lot of damage to me because I wasn't strong enough to drag myself around.
And it's also being very mindful that if someone is prescribed aids and adaptations, that they're taught how to use them properly.
Yeah.
So, for example, the crutches that you have on the screen, Kate, we quite often see that people are transferring out of their chairs by pushing up through their crutches.
Yeah.
And, having your arms up in a position where you're pushing up with your shoulders up and your hands up is not a normal way of transferring.
Yeah.
And that in itself can cause secondary pain issues. So whatever, there is a time and a place for aids and adaptations, but people should be aware of how to use them properly,
Yeah.
and they should be a plan should be made as to how to move away from using them over time using a rehab
Yeah.
approach,
Yeah.
if and when appropriate.
Mm. Yeah, and I know for
Yeah.
me, there was no training on that. It was basically sent home, and I'm like, well, what's the transition? You know, so I
Yes.
went down to
Yeah.
one crutch, and I was dragging myself along even more, and I ended up with much more severe right-sided pain. And
Exactly.
I just became, not strong enough to use them keep dragging myself.
Yes. Yeah.
Yeah,
Of course.
yeah. Yeah,
Yeah.
and the other thing, of course, is we've talked about the boom and bust approach. So I think a lot of us push ourselves as hard as we can go, and then become
Mm,
so weak that we can't do anything.
exactly.
Yeah,
Exactly.
yeah,
Yeah, and unfortunately, pain and fatigue does tend to go hand in hand with FND, and
yeah,
understandably so when you think about the impact, but the way that FND is generated as well. Yeah.
yeah, yeah. All right. So types of therapy, we've talked really a lot about, types of interventions that people might have. Are there any types of therapies that an occupational therapist might use for people with FND?
So, I mean, as you know, Kate, OTs have a very wide and varied role,
Yeah,
but it can, if we're thinking about the kind of things that we might do day to day, we've spoken about teaching and implementing normal movement
yeah,
strategies within function, fatigue and pain management, anxiety and relaxation strategies, if that's relevant for the person. Graded task practice makes up a lot of our time with patients with FND.
yeah,
So that's identifying something that the patient might find difficult or challenging, and reintegrating them into that activity using a very graded step approach,
yeah,
um, whilst also implementing taught symptom management strategies for the FND.
yeah,
Um, we, of course, OTs get involved with vocational rehab. So that could be trying to either help sustain someone in work or sustain someone in their study or voluntary roles.
yeah,
But it can also be helping a person with FND withdraw positively from work
yeah,
or study as well, because sometimes work is a significant maintaining factor for
yeah.
functional symptoms.
And a lot of
Um,
people are not able to return to the type of job that they had.
yeah, exactly, exactly. So vocational rehab can, be quite a varied role again, but it could be liaising with employers or universities or schools on the person's behalf, speaking about what FND means and how that might impact upon their role engagement.
Yeah,
But also how symptom management strategies can be integrated within their vocational tasks as well,
yeah,
and how employers can support that, and sometimes that's through implementation of reasonable adjustments.
yeah,
Sometimes it's about having extra rest breaks, or maybe extra time for exams, or
yeah,
extra time for assignments, or just providing, support in meetings, for example.
mm,
So that vocational rehab role can be very varied.
yeah,
Um,
yeah,
we also might, obviously OTs is about getting people back involved with tasks that they want to do. So that could be domestic tasks, parenting roles. One of the other things that we do is supported risk taking. So we mentioned briefly in the context of functional seizures that, understandably so, people with functional seizures often disengage from tasks that they perceived to be risky.
yeah,
Uh, but when that happens, people's worlds get smaller and smaller.
yeah,
And then every time they try and re-engage in a similar task, it can become very overwhelming and very scary.
yeah,
So a key role for occupational therapy is supported risk taking, and again, reintegrating people into normal day-to-day tasks in a very graded way. whilst using taught symptom management strategies for their FND.
Yeah, yeah.
Yeah.
And as you know, you mentioned employment and study, that sort of purposeful activity is really important for people's life, so that the world is not getting smaller and that they're still engaged and they feel they have a purpose and meaning in life. So it's really
Of
important.
course.
Yeah. And
Yeah, and
accommodation, yeah, accommodation in
yeah,
the workplace is just so important for people to feel that they can keep working. Yeah.
of course. And of course, there's also huge financial implications as
Yeah,
someone loses their job as well.
absolutely.
And we all know that financial stresses can be huge maintaining
Yeah,
factors
yeah,
for functional symptoms, because it's incredibly stressful to have
yeah.
a loss of income.
Yeah, yeah, very much.
Mm,
End up being, financial stress and loss of identity and loss of purpose and loss of meaning. So
of course.
yeah, so
Yeah.
really important. Yeah,
Yeah.
yeah. Alrighty. And you mentioned earlier about distraction. And so this relates to, papers are often referring to this, when the person's attention is distracted, the movement disorder symptoms might disappear or dampen.
Yeah.
So you mentioned that a bit with that tremor entrainment. Does that happen with other symptoms of FND, like functional motor symptoms? Can we improve people's well-being and recovery through the use of distraction?
Definitely. And I mean, I guess, again, that's the beauty of occupational therapy, in that we use function as a form of treatment. So
Yeah,
engagement in daily activities. And in essence, that engagement in the daily activities can be a form of distraction.
yeah,
And so as we mentioned before, you'll very commonly see that a patient's symptoms might not be as prominent when they're really engaged in something of meaning, or something that they're enjoying,
yeah,
or even if they're engaged in a really a good conversation with someone.
mm,
So intervening at the level of function is a form of distraction in itself.
yeah,
But other distraction techniques that can be really helpful are, some people find when they're up and moving around that having some music on in the background is really helpful, or when they're engaged in a cooking task.
mm,
They might find that if they're really engaged in a conversation, that their focus is taken off the symptoms.
mm,
If we had someone up, for example, in a standing frame, when you've got a captured audience, they can't go anywhere. Sometimes, we put music on in the gym a lot.
mm,
We play mind games. We might play play a board game whilst they're up, and we're increasing the
yeah,
weight bearing in their legs.
mm,
Also, sometimes if people focus in on another symptom management strategy, such as diaphragmatic breathing, that can actually take focus off the symptom, because they're really focused in on another strategy.
yeah,
So the idea is to try and take their focus off the symptom at hand and take their
yeah,
mind somewhere else.
yeah.
Yeah.
Yeah, and that's important. I think
Um,
a lot of rehab, certainly that I've been to, they're very focused on the symptom or the task or the walking, and have found your symptoms sort of exacerbate. Your walking gets worse when you're focused on it. Yeah,
of course,
yeah,
because movement should be happening at an automatic level,
yeah,
and unfortunately, that's what FND does. Is it makes it kind of breaks down automatic movement.
yeah,
Inadvertently, and without conscious control, attention gets driven towards the body.
mm,
Yeah.
yeah. And I've often thought, if we were doing sort of dancing, I used to dance a lot, which I haven't been able to do too much, but I thought if we incorporated dancing into physio, I might be a bit better, because then you're sort of thinking about dance moves rather than focusing on, the
Yeah.
symptoms. So I think it's
Yeah,
worth
certainly.
looking at.
Yeah, my team
Yeah,
does that a lot.
yeah,
Yeah, we've had a number of professional dancers with FND, actually.
yeah,
So of course we
yeah,
incorporate dancing into their treatment.
yeah, mm,
Into their treatment, we use things like yoga and Tai Chi a lot.
yeah, yeah,
Because if you're focused in on a symptom, focused in on a actual technique, attention can be
Yeah.
taken away from the symptom. Yeah.
Yeah, I agree that, like with the Tai
Yeah.
Chi, you're focused on that deliberate movement. So that's where your
Yes.
attention is. And it's like with dancing, when you're trying to remember the steps and the different types of movement, that's what you're focused on.
Yeah. Yeah.
Yeah, yeah,
And the other thing, the other strategy that can be really helpful, Kate, actually, is having a mirror in front, because you would think that actually that would draw attention to the body, but what we find is that a person's attention is kind of outside of their body
yeah,
looking into the mirror,
yeah,
and that can be really helpful to access normal movement.
yeah, yeah.
Um, yeah,
And I can
so we do
remember,
use it
yeah,
a lot.
yeah, I've had that mirror in front of me, and you're focused on, you know that the movement looks wrong, so you're focused on trying to get it right and to visualize it in the mirror. Yeah,
Yes, yeah. And
yeah,
again, you mentioned visualization. That's a really good
yeah,
strategy as well.
yeah,
Yeah,
yeah.
yeah.
Julie, were you about to say something?
Oh, I was just about to say, because I had a multidisciplinary treatment with a neurologist, Dr. Alex Len in Brisbane, and
Great.
yeah, I was really fortunate. And the physiotherapist, the neurophysiotherapist, actually did Glenn Nielsen's approach. But I always remember when you say distraction and automatic movement, and losing the whole ability of automatic movement. I remember one time I was at the bar and we were trying to do side movements, and I could go one way, but the left side was affected. You know, it was very weak, heavy, etc. And I always remember standing there and absolutely trying so hard to lift my left leg to move it to the side. And I remember saying to Darsha, my physiotherapist, I said, I can't do it. It's so heavy, and I didn't know, do I lift it? You're totally focused on how did I do it? Just a simple movement. Anyway, Darsha just, without my knowledge, just flicked her finger against my left leg, just below the knee. And my automatic response just kicked in. It was the weirdest feeling. And then I got so excited because I said to Darsha, I don't want to forget this movement. And I kept walking to the side numerous times because I didn't want to forget how to do it.
Yeah.
And it's so, when you're experiencing that, it just a simple distraction, can make all the difference. And it actually kicks in the automatic movement, and it's like, oh my gosh, I'm moving, and I'm moving correctly. So it's a huge journey. And I think also it's really important to let people know that it's you're sort of moving at a turtle's pace. The journey of rehabilitation with FND, it takes months and months. It's not days. And learning to move again, the simplest of movement, it's and learning how to pace with fatigue and all that, and with the chronic pain. So
And repetition and rehearsal is really key, isn't it? So mastering each step before you move on to the next one, and before you increase task complexity, is really important.
Absolutely.
Because as you can probably appreciate, Julie and Kate, that one thing that FND does is really knocks your confidence in your own abilities, and having confidence and in a step before you move on and increase the task complexity is quite important in building that confidence. And then confidence in your own body and in its capacities.
Yes, because we find on our group with our members that many people were were really high achievers. So we expect a lot of our bodies, normally before FND.
Yeah.
And we can push our bodies to the max, and our bodies respond really well. With FND, it's the total opposite. You can, the more you push, the worse you're going to be.
Yes.
Rest is absolutely key, and pacing, all that. It's a big learning curve.
Yeah. But also, Julie, getting a balance between work and rest. So what we don't want is to go the opposite way, because prolonged rest can then cause deconditioning, which can then, make pain and fatigue even worse. So it's a really fine balance, but that's why occupational therapy can be really helpful in helping people to find that balance between too much and not enough.
And it's also that balance can shift as well. So you might be, doing quite well and you can do more. And then, if you start to go backwards, then you've got to pull that balance back. And then, of course, people get that boom and bust approach as well, because they go, well, I used to do, so many hours up and work, maybe work 4 hours, and now I need to pull that back, or I need to increase it. So knowing, that balance in yourself, and if you get a virus that can knock you, or you're dealing with, I've got storm damage, things like that, external things that can impact, your well-being, and as it does for anyone. But just having that, being able to understand that balance and how much rest I need and how much work I can do without causing a relapse.
Yeah, exactly. And just, thinking about FND as something that will need ongoing management. So, even if you're having a period of symptom remission, you shouldn't get too complacent.
You
should have good occupational balance and good self-care. Because they're things that help to build stress resilience and help to build resilience to physical and emotional stresses as well.
And then some people think, okay, well, I've got no symptoms at the moment, I'm recovered and I get back to my normal life, and then all of a sudden they have another severe or worse relapse. So people can, the symptoms do start to improve, and then they sort of take it too far and end up in a worse state.
Exactly.
All right. Now, I know some OTs do sensory modulation, sensory integration. There's a sensory profile. Is this something that might help with people with FND?
Yeah, so it can be, Kate, and you will find that OTs that work in different countries will take a slightly different approach to sensory modulation treatment. So as you probably know, it's really common for people with FND to report hypersensitivity to touch, to light, to noise, to movement. And if, realistically, those problems are not just related to FND. They could also be present in people that have chronic fatigue or with chronic migraine as well. But as an OT, it's really important to get a sense of how that might impact upon a person, because it can impact upon the intensity of rehab that the patient might be able to tolerate. So you need to consider that as part of treatment planning and triage. So one of the things that we often do within our program, because many of our patients have sensory sensitivity, is looking at reintegrating someone into their environment in a very graded way. So if someone has been, just as an example, we quite often have people that, because of fatigue, because of pain, spend a lot of time in their bedrooms in a quiet environment in bed. But of course, if you're spending your time in a very quiet environment with altered lighting and not much noise, when you come out of that environment, it can seem a bit overwhelming. So we would do a very graded approach to introducing them to different sensory input in different environments. And that might be just starting with, a few minutes a day outside of their bedroom, and having meals at the dining table with the family, and then increasing the amount of time they're spending in family areas. We quite often see that because of sensory sensitivities, people might wear dark sunglasses or wear headphones. And what we would do is, again, in a very graded way, start to reduce the use of those kind of adaptive strategies. Because what we know is that although it seems right at the time, sometimes those adaptive strategies can make that symptom worse. But again, we might do a very graded approach to gradually reducing the use of those. Some people do use the Jane Eyre's theory of sensory integration, and that involves using a sensory profile. So a sensory profile is, again, sitting down with the person and working out what are the things that they are exacerbating their sensory sensitivities within their home and community environments. How long can they sustain being in those kind of environments? So you're looking at triggers and you're looking at capacities. And then as part of that, as part of a sensory modulation treatment program, it would be about combining compensatory strategies to inhibit and grade exposure, whilst also doing sensory-based activities to increase tolerances. So it's kind of a bit of both. And certainly in the States, and I know in Australia, the sensory profile can form part of occupational therapy treatment. And across the world, really.
And that's one thing you mentioned around the lights and the sensitivity. A lot of people do have that with FND. Is the bright lights, the shopping centres, the noise can be quite triggering to a number of people.
Oh, definitely. And that's why, rather than avoiding those environments, we would support the person in a very graded way to start to tackle those kind of environments. For short periods of time, and then increasing the amount of exposure time. Whilst also using other symptom management strategies.
Okay. And we often hear, people are told, oh, I just have to retrain my brain. And people are like, what is this? What is retraining my brain? What does rewiring my brain mean? And how can OTs help people with this?
So, I mean, in simple terms, we know that, kind of FND is related to the fact that the nervous system is not processing information in a normal way. Although there's no damage to the brain or the spinal cord, the way that the nervous system is working is not working efficiently and not quite working in the right way. So as part of that, what tends to happen is that the body can pick up bad habits, and it starts to move and interact with the environment in different ways. And abnormal ways of moving start to get laid down in the nervous system as the norm and normal. And so when you try and then occupational therapy is really good in terms of retraining the brain by taking focus off those abnormal ways of moving, and trying to use normal movement strategies within function, which is a form of distractor, to start teaching the body to work in more efficient ways, to start teaching the brain and body to interact with an environment in normal ways, so that we can help to break down these bad habits or break down these compensatory strategies or inefficient ways of moving. And again, part of that is through repetition and rehearsal and mastery of each step before increasing the task complexity. So just engagement in the functional activity with the use of normal movement strategies can, in effect, retrain the brain to work in more efficient and normal ways.
And that also aligns with not pushing yourself so that you're always doing bad movements, like I was dragging my leg along and sort of pushing myself, and then that was reinforcing, poor movement.
Exactly. So we kind of really reinforce with our patients with FND that we've got to get the basics right before we move on to the bigger and the hard things. Because what we don't want to do is carry bad habits forward all the time. And so if we notice that, so people might be moving for a short period of time with good quality, but then as they get more tired or their pain increases, some of the bad habits start to creep
bad
back in.
movements. Yeah.
Yeah, we would always get people to stop at that point, and we call it kind of resetting. So refocusing on your strategies, take a rest, and then start the activity again with good quality movement.
Yeah.
So that those efficient and healthy ways of movement get laid down, and they become the norm.
Yeah. Yeah. True.
Yeah. And then you build on endurance and length of activity from there with good quality.
Yeah. Yeah.
Mm.
Yeah. All right. And the other thing is how we use aids with people with FND, because some people are not able to walk with good movement for
Yes.
in the community, etc. So how do we make this decision around when we use aids, when we don't use aids? Prioritizing sort of independence as well. So, in terms of allowing people to do activities such as employment or study that's important to them. So at what point do we start to make these decisions?
So I think a provision of aids and adaptations, in the past, it's been quite a contentious issue for people with FND, I think. But actually, I would just really advocate for OTs to take a common sense approach. And that when you're thinking about providing a person with aids and adaptations, there shouldn't be any blanket rules. It should be considered on an individual basis, depending on that person's needs. We do know, as we mentioned before, that provision of aids and adaptations can cause secondary problems, such as increased pain and increase in deconditioning and reduced fitness. So if someone's presenting acutely, so what I mean by that is if someone hasn't had symptoms for all that long, then I wouldn't say go in and give that person, prescribe lots of aids and adaptations and major adaptations to the home. You would think about prescribing using a minimalist approach. So what are the things that the person is really struggling with on a day-to-day basis? Can we put a little bit of equipment in to increase functional independence and take away carer burden? And then what you do is, as we mentioned before, you teach that person how to use that aid appropriately and in the right way. And you make a plan as to how that person should grade off using that equipment, using a rehab approach. And that could be a plan over a series of weeks or months, or it could be a plan over a series of a few days, depending on how that person is presenting. So it's useful to think about the stage the person is at. It's a different situation if the person has had symptoms for a long period of time, or symptoms are quite chronic. In those kind of cases, the right aid and the right adaptation can really improve independence and improve quality of life. So again, you need to really consider the person's stage in terms of their symptom presentation, but also their lifestyle. So if someone has been off their feet, for a long time, and but they're housebound because they can't access the community, or they're too tired to self-propel to work, then in those cases, maybe, for example, provision of a power chair would mean the difference between being housebound and being able to independently access their own community and get re-engaged in meaningful activities.
No, and that's what you're saying. I mean, how long you've had it, what's your potential for improvement? Have you been trying to improve for a number of years and you're not? We see a number of people, mainly adults, that seem to be getting progressively worse. We tend to see children have a lot better outcomes than adults. And we have another number of adults that really, over a number of years, tend to be getting progressively worse.
Yeah,
And I think a lot of that has to do with we don't have a lot of FND trained clinicians. So I personally think that it's not so much on the person, it's if they're diagnosed in a timely fashion, they could be going for years and not have a proper diagnosis. Number two, a lot of people don't have access to multidisciplinary treatment with FND professionals. So you have an ideal situation where you diagnose very quickly, you have a multidisciplinary team working with you, and that sort of, you have a better outcome, I think. Whereas some people, I mean, there's no one size fits all, of course, with FND, but I think a lot of people that, they don't seem to, when Kate said we have a lot of people that are progressive with their FND, but then again, we have a lot of people that just can't access clinicians.
Yeah. And, being a very large, big country with only a handful of people in the country who are actually trained in FND, increases the challenges. We've had people moving across the country in order to access services, and some families can't do that.
Yeah, definitely. Yeah, it can be. And it's the same here in the UK as well. We have this term called postcode lottery. So it kind of depends on where you live as to what services you can access.
Yeah, and that's exactly what it is, really. I mean, with our paediatric program, it's in Sydney. There isn't another paediatric program in the country. We've had a good FND program in Brisbane. There hasn't been a good adult program, across the country.
No.
Yeah.
Exactly.
Yeah.
So does that answer the question about aids and adaptations, or were there further questions regarding that?
No.
Yeah.
I think that it's also, around, I mean, I know for myself, I had a point where I was housebound for 9 months because I just couldn't even walk to the letterbox, and I didn't have enough equipment to help me. And getting an electric wheelchair, which meant I wasn't strong enough to propel myself. But once I had that electric wheelchair, I could get a job, I could travel and re-engage in society. So my movement's not great. But for me, being able to do really important things, to travel, to run forums, meet people, work, has been really important. So there has been that balance around, using my body as much as I can, but also being able to engage in the activities that I want to engage in. So it did change my life because I was able to leave my house. I live on a very steep hill, and I just couldn't even leave my property. I'd fall into this cactus plant. So, I couldn't even. Yeah.
Actually, I would say also, Kate, for those people with FND that are worried that once they start using a power wheelchair that they'll never get out of it, and that's not necessarily the case either. So and we have patients that come into our program that are using power chairs, and they leave not needing the power chair anymore. So but again, it's about having access and timely access to the right type of treatment, and the treatment that's right for the patient, because one model might not fit everybody. The nature of FND is that it can change, and it can change over time. And even when people have had symptoms for quite a while, it doesn't mean they won't ever get better again. So but I think that's what I'm saying, is it needs to be done on an individual basis, and blanket rules don't really work.
No. Yeah. And that's why OTs are just going to be so important across the person's journey with FND, because, things change over time. People get better, they get worse, they relapse, that sort of stuff. So having an OT there to help that person make those decisions over time can be really important.
Yeah, exactly. Yeah. And we're really good at seeing the whole picture.
Yeah, that's right. And, there are a number of people who, despite their best efforts at treatment, they might have accessed, the best treatment program available, put, a year into trying to recover and just not getting there. Some people just don't recover. So how do we help, these people, this group of people?
So again, I mean, if people have had adequate access to specialist rehab or it's available, but they haven't been able to make gains, then maybe, a focus for occupational therapists, a focus on disability management and maximising quality of life might be the way forward for a particular group of patients. Yeah. So at times that can be looking at aids and adaptations and home modifications. The right home modifications and the right equipment might mean that a person can reduce their care needs and be more independent within their home and their community.
Yeah.
But as we've mentioned, given the nature of FND, things might change in the future, and timing for rehab is really important. So, someone, when they are offered rehab, it might not be the right time for them. There might be other things that are going on in their lives that are preventing, either full engagement or preventing recovery at that period of time. So I would say to patients with FND, don't feel afraid to ask for rehab again in the future if you feel that you think it would be beneficial, or you might be more ready to take up that option at a later date.
Yeah.
Because things can change over time and people can still get better later on.
Yeah.
And of course, then we mentioned it before, you asked about how you treat people who have variable and episodic symptoms.
Yeah.
That's really common with FND, and in fact, it's probably more the norm to have episodic symptoms than not. So I would say to people, if you have had a period of remission, don't get too complacent. You really need to think about keeping up your occupational balance. So having good self-care, eating well, drinking well, having good sleep patterns, not burning the candle, not overdoing things. Or if you're having a period where your symptoms are not going so well, try not to decompensate and just take to your bed, for example.
Yeah.
Occupational therapists can really help people develop a management plan for how to manage on good and bad days. Completing a relapse prevention plan or relapse management plan, which has a look at what do you know about your symptoms. So what are the triggers to your symptoms, how you might manage those triggers, what to do on a good day versus a bad day, having active reflection on if things are not going so well, have a think about why they're not going so well, and then make a change.
Yeah.
We would all do that if something wasn't going well in our lives, or we should do. So it's no different for FND, really. There's generally things underlying triggers.
And it may be that people have pushed themselves and they've gone back to work and tried to get back to their normal life too quickly, and just flares up again.
And people will be more, with FND, people will be more prone to having exacerbations of their symptoms when they're under physical and emotional stress. So we all of us, regardless of FND, need things in our life that help to improve resilience to physical and emotional stresses. So it's really important to include that in all of our lives so that we can stay on top of things. And not to let structure and routine slip. Because that's really important.
And so in Australia, we've got the NDIS, and people, some people are looking for, insurance, disability payments, disability pensions, because they're just not doing well. And people are often asked, for NDIS reports, is this condition permanent? So what is the role of the OT in helping people with these applications, getting a disability pension or getting on, assistive technology, that sort of stuff? So how can an OT help people in this?
So, I mean, it's fair to say that people with FND are entitled to disability benefits and pensions.
Yeah.
You know, they shouldn't be blocked from access to those.
Yeah.
OTs can help in a few ways in terms of benefits, but the systems involved with applying for benefits and pensions can be very difficult to navigate. So OTs can really help with people with their applications. They can help with explaining what FND is and explaining the functional impact on a person.
Yeah.
And thinking about how that might impact on their day-to-day functioning and their ability to earn money, for example, or ability to do things on their own, or whether they might have care needs.
Yeah.
The other thing that can happen is that occupational therapists can help with funding requests for specialist rehab as well. So outlining what the patient's functional impairments might be, how the symptoms are impacting, and how the occupational therapist thinks that specialist rehab might improve a person's function and might be of benefit.
Yeah.
So that can be really helpful to put down in a letter with the support of your occupational therapist.
Yeah.
OTs can also provide advice in terms of person's care needs and the extent of care required, and again advocate for a person's care on their behalf if that is needed. Where possible, we would definitely recommend care that is provided using a facilitatory approach. So what I mean by that is that care that works alongside a person to complete a task rather than doing a task for them.
Okay.
And certainly we as occupational therapists can have a role in training carers or training, whether that be informal carers, so significant others, or whether it be paid care. So OTs can go in and work with the carers to look at that facilitatory approach and kind of use the carers as co-therapists in helping to improve a person's independence and help them get back on track if that is possible.
Yeah.
And then of course we have things like rehousing that OTs might, well, certainly in the UK, I don't know about in Australia, Kate, but as an OT I quite often get asked to support bids for rehousing. And we do have a role in that sometimes a person's home is a maintaining factor to symptoms.
Yeah.
So certainly in the UK, many of the homes here are double story, and people are often restricted to their upstairs level of the house and can't get out of the house. So obviously that causes a lot of secondary problems, such as, you know, people become very socially isolated, people get very low in mood, and then that can exacerbate functional symptoms. So we can support bids for rehousing if it is necessary, or if overcrowding is a significant issue causing lots of stress, then or maybe there's neighbourly disputes, which mean that people won't go out of their house. So, you know, again, it's a bit similar to the aids and adaptations. You need to take it on a case by basis.
Yeah, very individual. Yeah.
Yeah, we wouldn't normally recommend rehousing in the acute stages, obviously, because things might change, and they might change quite quickly. So, again, a common sense approach goes a long way. Yeah.
All right. Well, thanks so much for your time and sharing all your knowledge about, you know, how occupational therapists can help people with FND. Was there anything that we haven't covered, do you think, that we need to let people know before we finish up?
No, I just think, I mean, if you have access to other healthcare professionals within your team, it can often be really helpful to work alongside them rather than in isolation. And the other thing to think about is that if your team has different waiting lists for different professionals, sometimes it can be helpful to join up and try and maybe change that, and maybe with patients with FND, well, for really any patient with long-term health conditions, having a joint up approach to rehab with various professionals is often more beneficial, because you can get a peer support from your colleagues, but you can also share treatment plans, and it can be more goal directed and be more rather than being quite providing disjointed rehab. So that's just something to think about for occupational therapists that are working with other professionals.
Yeah, which then supports that multidisciplinary team approach that we were talking about.
Yeah, exactly.
Yeah.
Exactly.
Well, thank you so much. Yeah, wonderful. Cool.
Okay.
All right.
Thank you.
Thank you. That's okay. Thanks, Julie. Thanks, Kate.
Thank you. Thanks.